just give you a little bit of my background. I graduated from Kansas State University with my dietetics degree, my bachelor's in 2000. And at that time, how many are focused on more clinical? Just so I get a feel. Raise your hands high so I can kind of see. And how many are more focused on the management side? Raise your hands high. Okay, well, so when I graduated that I didn't mind doing the clinical, but it wasn't where I felt my passion was at. I remember going through both my management and clinical semester, and I enjoyed both of them, but I recognized that management was what I really wanted to do. And I remember my preceptor at that time at the clinical side I was at, she's like, I think you're making a mistake, I think you need to stay in clinical, and I'm like, I really need to get to a job that has a little bit of mixture of both. And so I ended up getting a job at the hospital in Junction City, at the Gary Community Hospital, as the assistant food service director. And what that meant is I did both management and clinical. And I really enjoyed that because truly, food service operations can't happen. I mean, the clinical and food service really do work together. You can't do one without the other. Because if they're not providing quality food, who's not getting the nutrition? And so I did that for 2 years. Wasn't really looking to change where I was at. I knew the opportunities to grow, and that position was very limited. I wasn't looking, but they had a headhunter at where I'm at now who was looking for a dietitian to come full time. And so they had called me and said, would you come out and see who we are? I said, okay. Well, it's at Meadowlark Hills Retirement Community, and how many think that working in a nursing home is somewhere where you want to be? Well, you've worked there, so. And so I went kind of being skeptical because of what that is out there for nursing homes. Went and saw the beautiful facility, it's huge, and thinking, and they would talk about the different opportunities, so I took the job. And I remember the DON at the hospital said to me, Heather, I think you're making a big mistake. Long-term care is not where you want to be. I think you need to stay here. I'm like, no, I really think this is the direction I need to go. And I'm thankful for that because my passion is with gerontology. I love working with the residents that live at Meadowlark Hills and in that population. And I realized that back in high school, I worked out a swing bed at a hospital, and the residents I really enjoyed were the people that were on swing bed and were there long term. So I have been at Meadowlark Hills for 11 years. And when I started, I was the assistant food service director. I worked under a contract company named HDS, which I don't believe is even there anymore. I think it's gone. I think it blended, I don't know which one it blended with. But it'd be very much like Sodexo, trying to think of another one. What's another management? Aramark. Yeah. And so I worked with them under Meadowlark for about only 4 or 5 months, and Meadowlark's like, we're not doing this anymore. So they ended the contract with HDS, and obviously they saw something in me, and they said, because when you work for a contract company, if that facility, if they get rid of that contract company and that facility wants you technically in their contract, you're not allowed to work for that company. But Meadowlark was like, no, we're going to buy her out. So they bought me out, which I'm very thankful for, and became the full-time dietitian. And I focused, how many have been at Meadowlark Hills? Okay, so a few of you. We have what's called household model. So it's very different from a traditional nursing home. And so my job was to create the systems in the household model. We had some, but it was a mess. It had just transitioned, so we had just went from the institutional environment, and we just transitioned into these new environments, but there wasn't a lot of systems in place. And so with the help of a great mentor to me, we created the systems at Meadowlark for the food service operations in the houses, which is in the long-term care and assisted living. I did that for several years, so I still did the clinical, which was a big insight to me because what you're taught in school, there's not a lot on the long-term care side of it and how that process worked. So I really had to learn as I went. So I did the clinical, and I was doing the food service operation management for that side of it. I worked very closely with the person who oversaw all the food service operations because we also at Meadowlark don't just have healthcare, we have healthcare, assisted living, and independent living. So we are also serving the residents in independent living. During my time there, because I wanted more leadership role, I took on, I can't tell you how many titles I've had at Meadowlark. I've had too many to count. That's not always a good thing. I think we switched around too much. But just so you understand kind of the direction I went into operations and household. And so I kind of helped oversee some of the houses on how those operations work. So we kept with the system of the food service operations. Eventually, we built 2 new houses over there, so they have 20 residents in each house, and it was a really fun experience because I helped create the houses. They're way too big. We learned our lesson after they were built, but it's still neat to see your creation being done and creating those systems. They are 2 full food production kitchens, and we've kind of had some ebbs and flows through the year with that, and they went back and forth on being full food production, but, and I'll get to later, just recently we re-implemented that. We're having great success, and I think it's because of the oversight we're having with it and just re-implementing it. But it's probably the most successful it's ever been, actually, from even when you were there. It's really doing well. So anyway, I kept getting into operations, so I oversaw all food service operations, helped create the cafe. We have a cafe at Meadowlark. And then I also helped opening the restaurant in independent living. So that was kind of fun, something different. So it's not just in healthcare, but I got into the other side of it. And then what happened is then I went into assisted living and became an assisted living operations leader. And then from there, and during that whole time, I was getting my master's, graduated with my master's in hospitality management dietetics, and eventually became the health services administrator. So with that role, I oversaw all operations for both healthcare and assisted living. So it wasn't just focusing on food service anymore, it was focusing on all of it. The nursing, the environmental services, and that was a great experience to be part of that. So I've had various roles there, and then most recently I stepped out of that to have a little bit more balance in my life, because as you all know, when you get into leadership, it does take a little bit more. It was a 24/7 job, and you're working around 50, 60 hours a week, and I needed to take care of my 2 kids who are in the back here right now, and so I stepped out of that role, and then just recently decided to go back and get my PhD. So that's kind of the overall of what I've done. We've had a lot of groups come out to Meadowlark for different classes in the past, and I always tell people, a lot of people don't think of gerontology as a place to work. But as you all know, the baby boomers are coming, and it is going to be a huge area and a huge focus. So I would highly recommend anybody looking at gerontology, and there's a lot of changes happening in retirement communities. Has anybody heard of the culture change or person-centered care that's going on there? Mm-hmm. What have you heard about it?
Just it's a whole new direction, and they mainly focus on quality of life and the residents' needs, and a lot more about like the whole experience, not just like serving you, I don't know, like slop and plop type meals or I don't know.
That's right on. Anybody else?
I'd say it's pretty much the same as she said. It's just mainly doing the best you can to make the residents like feel like they're actually at home and that they're not in a retirement facility.
Yeah. And so that movement is happening, and what's neat, and if you ever get an opportunity to work for Meadowlark, which I'll put a plug in for that, because we're always looking for people who want experience in food service, that it is leading the nation in what we call culture change. So if you really want to understand what's going on, you get 2 options, 2 things you get there. You get your benefit of your experience, but you also get to experience what that culture change is all about, which can help you open your eyes to different opportunities for residents in other facilities too, as you go out being an RD. And so with that being changed, there is more focus on that dining. Dining is huge on empowering residents, because how many of us at 80 years old is going to want to eat a 1,500 ADA 2-gram sodium diet? How many's ever tasted one? Have you ever tasted? Have you ever heard what people mostly say about it? Or what do you think it would taste like?
Pretty bland.
Pretty bland, okay? And a lot of the research, when you're doing a lot of your clinical stuff, a lot of that research is based around our age group or a little bit older, but a lot of it's not focused on the gerontology population. And so a lot of times in long-term care, we're putting people on specific diets, and they're really not making that big of a difference. What happens is they're so bland and they don't have taste. So what happens when you age? What happens to your taste buds?
They diminish.
They diminish? okay? So if it's already bland, and you're losing your taste, or you've lost your sight, or anything else, are you gonna eat the food? No. So the goal is really to provide food that they're gonna enjoy and let them eat what they wanna eat. Because there really truly is not a lot of studies out there to say a 2-gram sodium diet is gonna help somebody. It could be very individualized, and there might be some that it does make a difference, but overall they have found, because there's a high tendency for malnutrition in long-term care because of the lack of eating, the lack of availability of food, because we put them in this institutional environment, they're not in their home anymore. They've lost that empowerment of making those decisions. And so now what's happening is that's being changed. And there's a lot of position papers out there on liberalized diets for long-term care that help to show how we can enhance that dining experience for them. So, any questions about that?
So in Meadowlark Hills, do you have like menus for them to order off of, like in healthcare and assisted living, or like
Yeah.
choices each day?
Yeah, we have a cycle menu. We have to have that. You know, there's regulations that come into long-term care. In hospital settings, there's regulations too. And so you do have to provide a certain specific menu, each day. The difference though is we're in houses, and so each one of those houses has, it just depends, like a microwave oven. The newest houses have full kitchens. You can cook anything in them. So our goal is to get as much in those houses cooked as possible, because what makes us want to eat? When we can see it, how it looks, how it tastes, right? And so our goal is to get as close to the residents and then help them prepare. So there might be a house that says, well, this Friday we're going to do chili and cinnamon rolls. And they're not using the menu, we're okay with that. Because it's being driven by the residents and it's what they're wanting. Or if someone doesn't want what's on the menu, that we have food in all those kitchens, so where they can prepare anything for the residents. So there's very much, just like you and I in our home, you can walk in, pull something out of the refrigerator just to eat it. Good question. Any other questions?
Does getting your PhD, like, is that related to different things, or is it just more knowledge in your?
For me personally, or?
Any?
Well, I think you can look at PhDs different ways. I do have my own thoughts with it. I think getting actual experience is very valuable. I think that teaches you a lot. Number one, is this what you want to go into? And I think a lot of your critical thinking, you learn it when you're on the job too. Yes, I think PhD has a value. I know that we have been just talking, there is a lot of openings that are going to be happening at universities to help or get teaching and research done for PhD RDs. So I think that is a big area to focus on, and honestly that's with any career, because a lot of the baby boomers will be retiring, and they've been saying this for a while, is there's not enough people behind them to fill all those positions than when they're retiring. So the same thing for our field too. I think there's different opportunities. For me personally, I always knew I wanted to get my PhD, just the timing of when that was going to happen. The reason I want to do it, honestly, is I want to focus with gerontology, and I want to make a difference. Really, truly, my passion is to make a difference for the residents that live in long-term care. And if the research I can show to facilities, because they resist a lot of change because either it's financial or it's too hard to do, and if I can show differently for them, I want to help with that. I think residents deserve to live differently than they do in nursing homes right now. They don't deserve to not have dignity, respect, and empowerment. They deserve better than that. They're the ones who built up this country, and then they're treated differently when they're in a nursing home. So it may be that I'm teaching at a university, or I might be back out in industry. I'm not putting my eggs all in one basket. I know the doors will open, and I trust that. I'm just where I'm at right now. So, but I think there is some value. I do think experience, though, first is more valuable.
How many residents do you guys have in Meadowlark?
We have around 122 in healthcare, around 45 in assisted living, and around 150 in independent living. So we're a little bit bigger retirement community.
Are you doing any research right now?
Say that again?
Are you doing any research right now, like working with your PhD?
No, well, I'm supposed to be starting my dissertation, and I haven't done a whole lot in it, but my research will be on looking at, I want to look at a facility that wants to go through culture change, and I want to look at them as an institutional environment. I want to see how the residents are perceiving the food and all of that, and then once they transition, and I don't know how this all will work yet, when they transition, to see if there's a difference in their satisfactions, difference in weight loss reduction, all of that can play into that. I truly think most things are pretty preventable, that nothing has to happen. It's how we limit what the resident has to be provided. So I haven't started research yet, but it'll be in my dissertation. So.
What was it like working under a contractor and then, I guess that transition into working at Metal Art full-time?
Yeah, that's a good question. I mean, I was only with them from I think it was May to October. So it was a very short time frame. I think contract companies are good because they already have a lot of the systems in place. Like if you need a resource, you just call them and they're going to provide it for you. So they already deal with, you don't really have to deal with the contracting of the vendors when you have a contract company doing it. So you're not sitting there trying to say, okay, I'm going to go with Cisco or I'm going to go with US Foods. They already know I'm in with Cisco and we're getting a significant discount. So a lot of the financial side of it, the contract company is going to help you a lot with that, or providing the forms that you need or anything like that. So that resource there is very nice. I think the difficult thing working for a contract, and probably something that I struggle with a lot, is I very much value being part of something. When you're with a contract company, you could either be by yourself, there might be one other person there that's with you on that team, that you're kind of looked differently as not part of the rest of the team of that organization. So I think I struggle with that because I really want to be part of the bigger picture of that team. So I think you have to be okay with that. You're on your own, you're there in that facility, but you have resources to call at any moment, but you're on your own there. Does that make sense? So I think that's one of the downfalls, but I think there's a lot to do with having the resources readily available and things like that. The transition, I was happy that the transition happened because part of it is when you're going through change, especially when you're changing the whole culture of how residents are living, your systems are all different. And so working in a contract company, they've already got their systems in place. They're not really budging on changing those. Whereas Miller's like, we're not making breakfast only from 7 to 8 in the morning. We're going to open it up to whenever we want. And so I think the contract company struggled with working with where we wanted to go with the culture. So that was the biggest reason that they stopped using them. So I was very happy that they left.
Are residents in the household stage able to request things they want to eat? Or do they have you a grocery list for them?
Yeah, no, they request whatever they want to eat. And what we do is once a week, the houses order food from our main kitchen. So we kind of look like our main kitchen is like a grocery store. And we never want to hear, sorry, we don't have that. That we have it. It's either in another house or we go down to the main kitchen and get it. And so the kitchens seriously are full of food. I mean, they're full of food. So it's rarely that we should hear someone doesn't have something to make for the residents. But you'll hear residents getting food that they'll be, sometimes people with dementia go through different phases. And that's something else you don't learn a lot about when you're going through your clinicals here. But dementia, I mean, you're going to work with that. If you're in the hospital or long-term care, people have dementia. Well, sometimes their cycle changes on their sleep pattern. So all of a sudden, they'll be sleeping all day long and then up in the middle of the night. Well, when we try to fix that and change it so they get their cycle back, what do you think happens with someone with dementia? Who's experienced someone with dementia? Okay, what happens when you change, when we push what we expect them to do? What happens? Yeah, because they're become aggressive. So then who do we assume is the problem? The resident.
Yeah.
And then they get medication because they're the problem. So what we do is we really honor where they're at and their patterns. So that may mean that we're making breakfast food in the middle of the night or preparing them something in the middle of the night to make sure they're getting their nutrition when they're awake. and not waking them up because we think it's time for them to eat. Does that make sense? So it takes everybody to understanding that process, so it's really truly about the resident, and it's not about us, and it's not about what we think is best for them. It truly is, what do we need to do for the resident and meet them where they're at? And I would highly encourage, if you don't know much about dementia, really look into that, because like I said, even if you're in a hospital, people do come in with dementia, and I think it's sometimes scarier there because they are so out of their norm and they don't know where they're at. And so a lot of times there might be some behaviors and it's not their fault. That's how we're approaching them all the times. Other comments or questions?
Can you talk a little bit about how much training it took with the staff when you went to a more culture change model?
Oh, yeah. Well, yeah, and that's constant. It's constant training. It was interesting when we went through that transition, because when did I ask already, how many have been in a nursing home? Okay, what do you feel when you walk into a nursing home?
I don't remember.
Kind of depressing.
Depressing?
That's what it's deal. Just
Okay, so you kind of felt that institutional environment? Well, think about what's happening to the staff that are working there too. They become institutionalized in that environment, so that's what they know, right? And it's not their fault, it's just what they were taught, that's what they were trained in. And so when you go through a change, and it doesn't, I mean, this can be a change for anything, it's really hard for us to change our habits, our behaviors, especially if that's what we have been ingrained to do, all of our life. And so it was really hard for people to take that transition of being okay letting someone sleep in as long as they wanted to sleep in, which meant that breakfast couldn't be at a certain time of the day, because if someone slept in at 10 o'clock, most places it's like from 7 to 8:30, and if it's after 8:30, sorry, we're not going to give you breakfast, okay? So it took a lot of training to help the staff be okay with it too, not knowing they're going to get in trouble, because for years they were told you get everybody up by 6 o'clock in the morning. You have their bath done by 7 o'clock, so they're all in a train, and then they're waiting to wait till the dining room opens and goes in. So it took a lot of education, a lot of meetings to discuss how these changes were going to happen to make them happen. But even after the change, it still took time, because we're so used to our habits that it didn't just happen overnight. So, I mean, it's pretty extensive.
Kind of going off that, I work at Mercy, and sometimes, like, when we send supplements up and stuff, it's hard to keep the other departments, like, wanting to help us with that. Have you seen stuff like that in your facility, and, like, how do you work with, like, say, the nursing staff or something to make sure that patients getting what they need?
Oh, that's a good question. We're blended in the houses, so what's really neat for Meadowlark is each house, everybody who is consistent to that house. So if I'm working in Haunstead, which is a house, I'm not going over to Lyle working in that house unless I choose to go do that. That is very consistent staffing. Well, what that helps with, so the nursing works in there, the CNAs, med aides, the homemaker, everybody's working in that house. So it really becomes they're the team that works together. There's no silo. We don't have silos. So I think that makes it more effective. And a lot of times when tour groups come in, they'll say, I don't even know who's who. They can't even tell you who the nurse is because they're all working together. And so what it also helps do is know the residents better. So for where you're at in the hospital, you guys really don't get to know the patients ever. Or they're gone in 3 days and you never know what happens to them. The benefit of working in long-term care is you really get to know the residents. You get relationships. Do you want to speak to that? Or?
Well, there was a lot of times when I first started where I would go up to somebody and ask if they would like to drink. They were like, whatever, I always get it. I don't really know. And it's like, okay, so I had to go ask somebody else, what does so-and-so usually get to drink for breakfast? Like, I don't know, I never really worked a breakfast shift. And they're like, oh, orange juice and coffee. So it's just nice to already know what they want. So when they're confused or they're having an off day, you don't even have to ask them. You just are like, oh, would you like this? They're like, oh, okay. And then that's exactly what they wanted. Usually, I mean, I always ask them what they want. And usually, like, I can say, how about this? And then they'll be like, okay, perfect. And whatever makes them happy. It's just easier to already know the residents.
So and you're going to see that in a hospital or there, I mean, we're still only less than 10% are actually doing any movement on the culture change. in the United States. So we have a long ways to go out of all the facilities, but there are still a lot of silos with that. And I've been working with a consultant group to say, how do you help everybody come together and understand it's an interdisciplinary team? And working through some teamwork on that to understand, because what happens is somebody else will do something over here and they're not communicating. So either it's the food service team that's frustrated because nursing just made change and they're not communicating when what's everybody here to do? To serve who we're here to serve, and we forget that sometimes. I do want to talk about supplements. I'm not a big fan of supplements. I see value in them to a certain point, but I'm very passionate about food comes first. And so, and I forgot to say, I am the dietitian again now, working part-time on getting my PhD. I won't order supplements. I won't even offer them. I'll talk to the individual, and if that's something they've been doing at home, that's what they've been doing at home, I'm going to honor that, but I'll talk to them about different ways. I very much have value about food first. So if we're giving a lot of supplements, something must be wrong with the quality, or they're not liking what we're feeding them. So for example, in a hospital setting even too, this is just my philosophy, if I was working in a hospital, why are we sending up that supplement? Obviously they're not eating very well, okay? So what diet are they on? They're 80 years old, we have them on what in a hospital? Okay, dysphagia, or we get into our restrictive diets. So if they're already lacking taste, they have a low appetite, and now we just serve them bland food. So instead of working on the quality and what's more important, getting that nutrition, because even if they eat 50% of that regular, they're not needing, their sodium level is not out of whack, you know, instead of having to get that supplement. How many have drink supplements? Okay, you all need to drink supplements. See what they taste like. There's some that taste fine, some of them are awful. And so just imagine you're serving something that you don't even know what it tastes like, and then you expect them to drink it. Okay, and we all enjoy different textures in our mouth. So if we're always being just offered the supplement, we're not even allowing that stimulation to happen for the residents. So there are hospitals going to liberalized diets. That is a new trend too, and so that's happening. So look for that, and it's basically you serve regular food or like a low concentrated sweet, you never restrict them from it. So maybe that's something you can look at for the hospital. I mean, I know that's a big change, but great questions. Anything else? Did I answer your question about the training?
Yeah, that was good.
Yeah. When we do training, I'm not saying it's perfect either, I should say this, you know, we have it set up now to they get 2 or 3 days of training. Is that right?
Something like that.
Okay. I don't know why I can't remember that right now, but we have all staff go through homemaker training, which is where the food service part of it comes in, and I'll tell you, I don't like the word dietary. It's like my biggest pet peeve, so I don't even like to use the word, because I think we're more than that. But anyway, all staff who work in the houses go through homemaker training because it's a blended opportunity. It doesn't mean when we create those silos, someone can't just say, oh, I can't go to that kitchen, that's not my area. We want everybody to feel comfortable going to that kitchen and making whatever it is for the resident that they want, just like you and I would want in our own home. So. All right, anything else? Well, thank you.